ECG manifestation of junctional rhythm has been conventionally divided into high junctional, mid junctional, and low junctional. In high junctional rhythm, inverted P waves occur before the QRS complex and there is a relatively short PR interval. Mid-junctional rhythm is characterized by absence of P waves as the P waves are supposed to be simultaneous with the QRS complexes. Low junctional rhythm manifests inverted P waves after the QRS complex in the ST segment with a short RP interval. In all these types, the rate is around 40 to 60 per minute. Mid and low junctional rhythms are associated with regular Cannon waves as the atrial contractions occur during ventricular systole when the AV valves are closed. This ECG shows a slow regular rhythm with a ventricular rate of around 43 per minute. Though there are some baseline artifacts, no definite P waves or fibrillary waves are seen. If the baseline artifacts are considered as fibrillary waves, then it has to be considered as atrial fibrillation with complete heart block and a junctional escape rhythm. If the baseline artifacts are ignored, it becomes a mid-junctional rhythm. Alternate possibility in view of the tall peaked T waves is an atrial paralysis with sinoventricular conduction in hyperkalemia. ECG shown here illustrates junctional rhythm with retrograde P waves or P' waves. P' waves are seen on the ST segment in V1 preceding the T waves, which are better seen in V2 than in V1 and hence marked in V2. QS complexes are noted in inferior and anterior leads indicating old anterior and inferior infarctions. The QRS complexes are not preceded by anterograde P waves. Retrograde P waves in the ST segment will make this a low junctional rhythm. Low atrial rhythm manifests with inverted P waves in inferior leads. It may be seen in sinus venosus atrial septal defect. This ECG shows inverted P waves in inferior leads 2, 3 and AVF. This indicates that the atrial activation is spreading from below upwards. It is suggestive of a focus either in the low atrium or high junction, but the rate of around 75 per minute indicates the possibility of low atrial than high junctional rhythm. There is notching of the QRS complex in the inferior leads, which suggests the crochetage sign in atrial septal defect. Low atrial rhythm can occur with sinus venosus atrial septal defect as the sinus node may be defective, and so alternate focus arising in the low atrium gives the dominant rhythm. Multifocal atrial tachycardia can be defined as the occurrence of 3 or more different morphologies of P waves at a rate more than 100 per minute. Multifocal atrial tachycardia is sometimes called as chaotic atrial rhythm because of the variability in atrial activity. Multifocal atrial tachycardia can occur in those with chronic obstructive lung disease. This ECG shows multiple morphologies of P waves marked M seen in short runs of tachycardia. This is characteristic of multifocal atrial tachycardia. Sinus P waves marked S are seen after the pauses. Atrial fibrillation is the most common sustained arrhythmia. AF can be recognized in the ECG with absence of organized atrial activity and the presence of fibrillary waves. AF can be either fine AF or coarse AF depending on the amplitude of fibrillary waves. Fibrillary waves of more than 1 mm amplitude is called coarse AF and indicates atrial enlargement. AF can occur acutely in situations of sympathetic overactivity or due to rapid dilatation of atria due to ventricular dysfunction. Chronic atrial dilatation and fibrosis predisposes to persistent atrial fibrillation. In chronic AF, there is electrical remodeling of the atria. ECG showing atrial fibrillation with slow ventricular rate. Fine fibrillary waves are seen throughout the baseline, indicating fine atrial fibrillation. Slow ventricular rate suggests that AV nodal conduction is defective, either due to disease process or drugs like beta blockers or digoxin. Atrial fibrillation with aberrant ventricular conduction will present as wide QRS tachycardia resembling ventricular tachycardia. Aberrancy could be transient aberrancy occurring due to fast ventricular rate causing aberrant conduction in one of the bundle branches, usually the right bundle. Alternatively, it could be pre-existing bundle branch block on top of which atrial fibrillation occurs. Yet another reason for wide QRS in atrial fibrillation is pre-excitation, WPW syndrome. In WPW syndrome with atrial fibrillation, ventricular rates can go very high due to simultaneous conduction through normal AV nodal pathway and the accessory pathway. Unlike the normal AV nodal pathway, whose refractory period increases at fast rates, accessory pathway refractory period shortens at fast rates and can lead to dangerous ventricular rates degenerating into ventricular fibrillation. Hence, AF with WPW syndrome is often associated with hemodynamic compromise and an indication for rapid electrical cardioversion. Shortest RR interval will be equal to the refractory period of the accessory pathway. ECG showing atrial fibrillation with WPW syndrome causing a wide QRS tachycardia. Usually this is mistaken for ventricular tachycardia in the emergency department and cardioverted because of almost invariable association of hemodynamic compromise. Close inspection of the ECG, often retrospectively after cardioversion, shows the distinct variation in cycle length, over 50% difference between the shortest and longest RR intervals, indicating the underlying rhythm is atrial fibrillation. Fibrillary waves of atrial fibrillation are seldom seen in this situation as it is fine AF in the absence of atrial enlargement. A good baseline to demonstrate fibrillary waves is also unlikely at such fast rates. In addition, there is variation in QRS width known as concertina effect due to the varying degrees of pre-excitation for each QRS complex. These two features differentiate it from ventricular tachycardia. Moreover, post-conversion ECG will show classical features of WPW syndrome with short PR interval, initial slurred part of QRS known as delta wave, and secondary STT changes. Therefore, the dictum that we should always take a repeat ECG after treatment of any sustained cardiac arrhythmia. Typical atrial flutter manifests as sawtooth waves in inferior leads. Usually, the conduction ratio is 2:1, so that there will be double the number of flutter waves compared to QRS complexes. But alternate flutter waves are not evident, being masked by the overlying QRS complexes. When the conduction ratio is 3:1 or 4:1, the flutter waves become more evident. Carotid sinus compression can change the conduction ratio and make the flutter waves visible during continuous monitoring in an intensive care unit. Administration of adenosine has a similar effect and multiple sequential flutter waves will be visible during the transient atrioventricular block produced by adenosine. Atrial flutter is often missed on an ECG because the alternate flutter waves are masked by the QRS complex. A high index of suspicion is needed to diligently look for flutter waves in a supraventricular tachycardia at a rate of around 150 per minute, which is the typical ventricular rate in atrial flutter with 2:1 conduction. The typical atrial flutter rate is 300 per minute and commonest conduction ratio is 2:1, so that ventricular rate is 150 per minute. Atrial flutter with inverted flutter waves in inferior leads is called typical atrial flutter. When the flutter waves are upright in the inferior leads, it is called reverse typical flutter. Both these types of flutter are due to macro-reentrant circuits within the right atrium and are dependent on a zone of slow conduction in the cavo-tricuspid isthmus. Typical flutter has anti-clockwise intra-atrial reentrant circuit, while the reverse typical flutter has a clockwise reentrant circuit. Both types can be cured by ablation in the region of the cavo-tricuspid isthmus. Atrial flutter, being a macro-reentrant arrhythmia, is the one which is most sensitive to direct current cardioversion. Low energy levels of the range of 25 joules are sufficient to convert the flutter to sinus rhythm, though it may recur if the underlying cause is remaining untreated. ECG showing atrial flutter with 2:1 conduction. Alternate flutter waves are masked by the QRS complexes. Another ECG showing atrial flutter with 4:1 conduction. Atrial rate is 272 per minute and ventricular rate 68 per minute. Flutter waves in inferior leads are upright, suggesting reverse typical flutter. QRS complexes are wide and shows left bundle branch block pattern. Ventricular ectopic beats are also known as ventricular premature beats or complexes. VPB or VPC, sometimes PVC, premature ventricular complexes. They originate mostly due to re-entrant circuits within the ventricles, but could also be due to triggered activity. Ventricular premature beats are easily recognized on the ECG by their wide bizarre QRS complexes, not preceded by a P wave. Secondary STT changes in the form of ST depression and T wave inversion when the QRS is dominantly positive are also seen. VPC is usually followed by a full compensatory pause, meaning that the interval between the previous sinus beat and the next sinus beat will be exactly double that of the sinus cycle length. This is because the VPC does not reset the sinus cycle, unlike the supraventricular ectopic, which gets conducted to the sinus node earlier and resets the sinus cycle. Basic rhythm in this ECG is sinus rhythm at around 60 per minute. There are two wide QRS complexes seen in lead 2 rhythm strip. Both are of similar morphology, hence they are called monomorphic VPC. Monomorphic VPCs are usually unifocal and have same coupling interval. Coupling interval is the interval between the onset of the previous normal QRS complex and the ectopic QRS complex. Ventricular ectopic is identified by the absence of preceding P wave, bizarre wide QRS and secondary STT changes. It is usually followed by a full compensatory pause, meaning that the sum of the coupling interval and the compensatory pause will be equal to twice the regular sinus cycle length marked as RR in the ECG. Compensatory pause is the interval between the onset of the ventricular ectopic beat and the succeeding sinus beat. The full compensatory pause is because the ventricular ectopic beat usually does not reset the sinus cycle. This is because the next sinus discharge would have already occurred before the ventricular ectopic impulse gets conducted up through the atrioventricular node with the usual delay. Ventricular ectopics with different morphologies can be called polymorphic VPC. Polymorphic VPCs are more likely to lead on to more complex ventricular arrhythmias. They usually have different coupling intervals as they originate from different foci in the ventricle. Polymorphic VPC were also called as multifocal VPCs. One classical type of polymorphic VPC is the bidirectional VPC with alternating QRS complexes being positive and negative. Bidirectional VPCs are the forerunners of bidirectional ventricular tachycardia, which is one of the types of polymorphic ventricular tachycardia. Monomorphic VPC usually lead on to monomorphic ventricular tachycardia. VPCs with short coupling interval are more likely to precipitate ventricular tachycardia or fibrillation. When the R wave of a VPC falls on the T wave of the previous cycle, it is known as R on T phenomenon, which is a forerunner of ventricular fibrillation. This is because the initial part of the descending limb of the T wave is the most vulnerable phase in the electrical cycle, which is more prone for arrhythmia. Initial two VPCs in this ECG are isolated VPCs, while the last two occur in rapid sequence as a couplet. VPC couplets may be a forerunner of ventricular tachycardia. Isolated VPCs and the couplet are followed by a compensatory pause. All the VPCs have same morphology, monomorphic, indicating the same focus of origin, unifocal. Unifocal VPC usually have the same coupling interval. The couplet occurs at a cycle length of 400 milliseconds. If this progresses to a ventricular tachycardia, expected rate will be 150 per minute. Two beats in the couplet do not have identical morphology in all leads. Have a look at leads V4 to V6. This may indicate either different foci of origin or different conduction paths in the ventricle. Moreover, the inter-ectopic interval is shorter than the coupling interval of the VPCs. Complex ventricular ectopy is the occurrence of multiple bizarre QRS complexes without preceding P waves and having different morphologies and coupling intervals. Since they have different morphologies, they are unlikely to be amenable for radiofrequency catheter ablation as they originate from multiple foci. Complex ventricular ectopy, occurring frequently over a long period of the order of a decade, can predispose to tachycardiomyopathy. Tachycardiomyopathy is a condition in which long-standing fast heart rate predisposes to left ventricular dysfunction. The dyssynchrony of the left ventricular contraction due to altered sequence of activity during ventricular ectopy is an important contributor to the left ventricular dysfunction. On the other hand, complex ventricular ectopy can be an association of familial dilated cardiomyopathy as well. When each sinus beat is followed by a VPC, it is called ventricular bigeminy. It is associated with pulsus bigeminis. In the yesteryears, when digoxin usage was high, ventricular bigeminy used to be an important manifestation of digoxin toxicity to look for. Ventricular premature complexes are seen alternating with normal sinus complexes in ventricular bigeminy. VPCs are identified as bizarre QRS complexes not preceded by P waves and occurring before the expected P wave in a premature fashion. In this tracing, the normal P waves originating from the sinus node are seen as small humps in the ST segments of the VPC. In this case, as P waves during the VPC are occurring when the atrioventricular walls are closed due to ventricular systole of the PVC, they will produce regular cannon waves in the jugular venous pulse at a rate half that of the ventricular rate. The pulse will be showing a patterned irregularity in the form of pulsus bigeminis. The premature pulse will have a lower volume compared to the sinus beat because of reduced time for ventricular filling. Sometimes the pulse may not be felt during the VPC so that it may appear as a bradycardia. This can occur if the beat is so premature that the ventricular contraction is not forceful enough to open the aortic valve. In that situation, the first heart sound is not followed by a second heart sound as the aortic valve remains closed throughout that cardiac cycle. Ventricular premature beats are the commonest cause of a cannon wave as they are much more frequent in incidence than complete heart block, which is the more well-known cause for cannon waves in the jugular venous pulse. Bidirectional VPC and bidirectional ventricular tachycardia, in which consecutive VPC had QRS complexes of opposite polarity, were considered classical features of digitoxicity. When every two consecutive sinus beats are followed by a VPC, it is called ventricular trigeminy. Similarly, when three consecutive sinus beats are followed by a VPC, it is called ventricular quadrigeminy. These are associated with corresponding changes in the pulse. The pulse of a VPC is usually of low volume, so that sometimes it may be hardly felt. In some cases of ventricular bigeminy, this may lead to miscounting of pulse rate, and the pulse rate will be counted as half the heart rate and bradycardia alert issued by the ward staff. The pulse following the compensatory pause has a higher volume because of better ventricular filling during the pause and enhanced inotropy. Multiple wide bizarre QRS complexes without preceding P waves are ventricular ectopic beats in this ECG. Since they have different morphologies, they are called polymorphic VPC. Some of the couplets are seen to be bidirectional VPC, while others are unidirectional. In addition, There are QS complexes in V1 and V2 with a slightly curved ST segment and T wave inversion reminiscent of an old myocardial infarction. Bidirectional VPC and bidirectional ventricular tachycardia can be seen in digoxin toxicity, Anderson-Tawil syndrome, the congenital long QT syndrome 7, catecholaminergic polymorphic ventricular tachycardia, myocarditis, myocardial infarction, and metastatic cardiac tumors. Reference for bidirectional ventricular tachycardia. ECG showing ventricular ectopic bigeminy. Clinical findings will be pulses bigeminous and intermittent cannon waves as alternate P waves are falling on the ST segment. When P waves fall on the latter part of the QRS, ST segment or T waves, cannon waves can be expected as QT interval roughly represents the electrical systole of the ventricle. Diastole ends and systole starts at the peak of the R wave. When P wave occurs during ventricular systole, atrioventricular valves are closed and cannon wave occurs. In the tracing, P waves are seen as distortions in the contour of the ST segment of the ectopic beat. The distortion is exactly midway between the preceding and succeeding P waves of the sinus beats which are of narrow QRS. Ventricular ectopics are characterized by wide bizarre complexes which are premature and not usually preceded by P waves. Monitor screenshot showing ventricular premature complexes occurring in a trigeminal sequence. Two sinus beats followed by a ventricular ectopic beat. Ventricular trigeminy or VPC trigeminy. T waves of the sinus beats are widened. VPC occur after the next sinus P wave and can be called late diastolic VPC. Late diastolic VPC can occur during reperfusion of occluded coronary artery in acute myocardial infarction. They can be followed by accelerated idioventricular rhythm, a classical reperfusion arrhythmia.